A 30-year-old male patient presented with sudden painless diminution of vision in the left eye for last 7 days. The vision in the left eye was as low as 660 N36. The right eye fundus was within normal with a vision of 66 N6, and the left eye fundus showed a large submacular cyst resembling a white pearl with a high reflective center suggestive of cysticercus cyst with a central scolex. The OCT showed a hypoechoic area in the subretinal space with a high reflective center suggestive of scolex. Fundus fluorescein angiography showed pooling of the dye within the cyst with a hyperfluorescent area adjacent to it suggestive of the point of entry of the cyst into the subretinal space with some RPE alteration surrounding it. The ultrasound B scan showed a dome-shaped moderate reflective echo temporal to the optic nerve head with a high reflective central dot echo suggestive of scolex. Patient was started on oral corticosteroids 1 mg per kg body weight, followed by pars plana vitrectomy under local anesthesia and under guarded visual prognosis. The cysticercus cyst was seen in the submacular space. The undulating movements of the cyst were well appreciated on throwing the light from the endolight. It was indeed a dancing delight to my eyes. Intravitreal triamcinolone was then injected to stain the posterior hyaloid face. Posterior vitreous detachment was induced using active suction from the vitrectomy cutter. Subsequently, the vitrectomy was then completed. The cyst was still busy dancing. A 41 gauge cannula was then used to inject the saline in the submacular space. Simultaneously, perfluorocarbon liquid bubble was injected over the optic nerve head. Some more saline was injected through the 41 gauge cannula. Minimal bleed did occur at the point of injection. And some more perfluorocarbon liquid was injected and the size of the bubble increased. As the cyst moved towards the opening of the 41 gauge cannula, a beautiful foveal reflex could be well appreciated. It appeared like the cyst was moving towards the 41 gauge cannula opening. A soft tip cannula was then used to take out the cyst into the vitreous cavity. The cyst was delivered using a soft tip cannula in toto into the vitreous cavity. The cyst was then eaten away using the vitrectomy cutter. This was followed by fluid air exchange. And laser was done to the opening of the 41 gauge cannula, which had enlarged during the removal of the cyst. This was then followed by exchange of air with 20% of SF6 tamponade. MRI brain was done, which showed disseminated hypointense nodular lesions with eccentric hyperintensive focus, few associated with surrounding edema suggestive of neurocysticercosis. Patient was started on anti-epileptic and anti-helminthic drugs, and the oral steroids were continued. At 6 months follow-up, the patient recovered a vision of 612N9 in the left eye, and the fundus was stable. And the OCT showed normal foveal contour in the left eye. Cysticercosis is a parasitic tissue infection caused by larval cysts of the tapeworm Taenia solium. These larval cysts infect the brain, muscle, or other tissues and are a major cause of adult-onset seizures. Cysticercosis is spread by contact with tapeworm-infected human feces. Contaminated food, water, and dirty hands are all sources. Cysticercosis may cause lumps under the skin, and when it spreads to the brain or spinal cord, headaches and seizures may occur. Access to improved sanitation is the key to prevention of cysticercosis.